So good morning, everyone. So I'll be talking today about the anatomy of the rotator cuff muscles, and also trying to make it a bit clinical as well a bit later on in the presentation. So I wanted to just start with the shoulder joint and some of the muscles that surround the shoulder joint and are involved in the movement of it. It's sort of split up into two sort of groups. You've got your extrinsic muscles of the shoulder, and they're superficial and deep, and they include sort of those back muscles that sort of originate from the torso and insert onto the bones of the shoulder. You've also got the intrinsic muscles, so the scapulohumeral group, and they consist of 6 muscles. Your deltoid, which is one of the main abductors, your teres major, which is an adductor, plus the 4 rotator cuff muscles, which I'll go into in a sec. And they originate from the scapula and insert onto the humerus directly. You can't see the subscapularis in this because it's posterior view. So the glenohumeral joint first. So it's a ball and socket joint between the ball being the ball being the head of the humerus here, and the socket being the scapula. It comprises of large spherical head inside this small cavity, and what that means is that it's quite a mobile joint, but it can be also quite unstable. So in order to get the stability of the shoulder, there are 2 sort of main things which there are. So there's the static stabilizers, which are the non-contractile tissues. So the capsule, the labrum, the negative intra-articular pressure, and all the ligaments which surround the joint, as well as the dynamic stabilizers, which are the muscles, or the contractile elements. So they include the rotator cuff muscles and the long head of the biceps brachii. And I'll go into what dynamic stabilizing actually means in a minute. So here's a better view of the rotator cuff muscles. We've got a posterior view, which you can see 3 of the main ones, plus the anterior view, where you can see the subscapularis. So they consist of the supraspinatus, infraspinatus, teres minor, and subscapularis. And the useful mnemonic for us medical students is the SITS group. Their role is to allow a wide range of movement whilst providing that stability of the glenohumeral joint. So they've got a resting tone which actually pulls the head of the humerus into the socket, and this sort of keeps it centered during shoulder movements. So as I said, it's a dynamic stabilizer. This is just for completeness, because I'll go more into the muscle functions and the insertions and origins and all that stuff. But vascular supply, it's mainly through, each of the muscles are sort of a bit different. So suprascapular from the thoracocervical trunk, and then that'll sort of supply the supraspinatus and infraspinatus. And then you've got the subscapular artery, which will supply the subscapularis from the axillary artery, I think. And then you've also got the posterior circumflex humeral, which will supply teres minor. The lymphatics, they all drain to the axilla there as well. So this is just another pictorial just showing each of the 4 different rotator cuff muscles. The thing I just want to point out here is that these 3 muscles insert, so 1, 2, and 3. 1, 2, and 3 insert onto the greater tubercle of the humerus. You can't really see it here. You can see it better on the previous slide, but the subscapularis inserts onto the lesser tubercle, so that's sort of a way of differentiating between the different muscles. So we'll go through each of the different muscles in turn. So the supraspinatus, its origin is the supraspinous fossa of the scapula, and it inserts on the greater tubercle, as I mentioned. It's innervated by the suprascapular nerve, which comes from the superior trunk of the brachial plexus. And its main action is to abduct the arm from that 0 to 15 degrees. And after that, it assists the deltoid in abduction. It's the only one of these rotator cuff muscles that doesn't actually rotate the humerus, interestingly. The infraspinatus, it originates from the infraspinous fossa of the scapula and inserts on the greater tubercle of the humerus. It is also from the suprascapular nerve, and it involves shoulder external rotation. Teres minor, its origin is the posterior fossa of the scapula, adjacent to its lateral border, and it inserts onto the greater tubercle of the humerus, just like the others. It's innervated by the axillary nerves from that posterior cord of the brachial plexus, It is a long, sort of thin muscle and sometimes hard to differentiate from infraspinatus, and it is covered by a lot of deltoid. It is a weak external rotator of the shoulder, but its sort of more important role is to hold down that humerus against that upward pull of the deltoid to allow for that stability during abduction. Subscapularis, this one's the last one. Its origin is the subscapular fossa on the costal surface of the scapula, and this is the only one that inserts onto the lesser tubercle of the humerus. It's innervated by the upper and lower subscapular nerves from the posterior cord of the brachioplexus, and this one is mainly involved in internal rotation of the shoulder here. So this one, there is a bursa sort of close to this muscle, but the more important bursa is the one near the supraspinous muscle and near the tendon specifically, and that's where you get a lot of the clinical sort of anatomy and relevance to it, which I'll get into. This here is just a pictorial of what's called scapulohumeral or glenohumeral rhythm, and the rotator cuff muscles have an important role during this sort of process. So your lateral rotation of the scapula, there isn't really much in that first 30 degrees of shoulder abduction. Remember that the first 15 degrees of abduction of the shoulder is by the supraspinatus, and then after that the deltoid takes over to about 90 degrees. However, after this sort of point, if you're looking at the lateral rotation or the abduction sort of going to 180 degrees, the scapula is involved in about 60 degrees of this movement, and it'll rotate, and then the humerus itself is involved in the rest of it. And the importance here is that you do have this interplay between the rotator cuff muscles and the scapula in particular, but the scapula is important in that it rotating allows for that length sort of tension relationship to be maintained, so the tendons and the muscles don't become shorter, and then they can sort of hold the humerus in place as well within that glenoid fossa. So I won't get into too much of this. It's sort of coming towards the end of the presentation, but we'll go into this next week. I think Joe will. But there is a spectrum of pathologies. Very common cause rotator cuff pathologies. Very common cause of shoulder pain and weakness, but it can range from simple sort of tendinitis to muscle tears to inflamed bursa and tendons to even impingement and caused by degenerative processes. In younger patients, it's mostly related to injuries secondary to trauma or overuse, so repetitive sort of actions or improper technique. Incidence increases with age, as does all the sort of degenerative sort of changes in this region. And over time, as I said, the tendons and the bursa can get sort of inflamed, and the tendons themselves can get inflamed and cause impingement and be a sort of significant cause of that pain. So there are certain different physical exam signs and tests that you can sort of elicit some of these things. Usually you'd be doing all of these, and they might not be too specific for an individual muscle, but they're quite useful to know. So the supraspinatus, which a lot of your pathology sort of comes in, one of the tests is that empty can or Joby's test, as seen there, where you're abducting the shoulder and internally rotating while the examiner's sort of pressing down on the arm. The hornblower for teres minor. Again, you've got this arm in abduction, flexion, and then you're externally rotating against the resistance here. I didn't mention the infraspinatus, but that sort of is mainly, you go off more the action of what it actually does rather than a specific sign. And the subscapularis, there are a few different things which you can do. The lift-off thing here, where the patient puts their arm behind, so they're flexing, they're internally rotating, I think, and then the patient's got to try keep the arm on the back and not lift their arm off. The bear hug, same sort of thing. They've got to keep their arm on the shoulder and try not to resist that pull by the examiner there. Oh, sorry, the examiner's pushing in. They've got to push out. And then lastly, the supraspinatus tendinitis. So a characteristic sign is the painful arc test, and it's pain in the middle of abduction from that 60 to 120 degree mark. where the affected area comes in contact with the acromion here. So if you've got inflammation or even a tear, sometimes you can get this subacromial pain, which is distinct within this area as they come into contact there. But that sort of comes to the end of the presentation. The take-home messages were that the joint itself is quite mobile. I think it's one of the most unstable joints, if not the most unstable joint in the body. The rotator cuffs, or the sit screw, they're dynamic stabilizers of the shoulder joint to allow for the movement but also the stability. The rotator cuff's mainly involved in shoulder abduction and external internal rotation depending on the actual muscle involved. And pathologies can be elicited on physical exam and with that painful arc sign characteristic of supraspinatus tendinitis or tendinopathy or some sort of issue with that muscle itself. All right, there are my references, and thank you very much.
That was good.